Morning and welcome you all for another edition of Online Anesthesia Postgraduate Teaching Program on Zoom platform sponsored by Acrola and hosted by Aeon Logics. Today we have two interesting case discussion on mitral stenosis and mitral stenosis complicating pregnancy. Today moderators are Dr. Chaitanya and Dr.Rikesh. And the postgraduate from Kanyakumari Medical College, Dr. Praveena and Dr.Ramya are participating. Today's session will be coordinated by Dr.Rajesh, Jeyaprakash. So over to you, Dr.Rajesh.
Good morning, sir, and good morning, everyone. As sir told, today we have two interesting case discussions, and they are definite cases in postgraduate exams, both for national board and CMD exam. So we have two postgraduate teachers, Dr.Ramya and Dr. Praveena, doing MD in Kanyakumari Medical College, and they are final year PGs. And the two examiners for today's session are Dr. Chaitanya Kamath, my good friend, and she is from Karnataka. She had done currently as a professor JNMC, Belagavi. She had done a lot of achievements during her career, and she had got gold medal in the MD examination. And a very interesting thing is she is very much interested in teaching yoga. So you can see her as a faculty in almost all national conferences for yoga teaching. Welcome, Dr. Chaitanya. And the second examiner is Dr. Rikesh. It's a very proud moment for me because my own student conducting a session as an examiner, and he did DNB anesthesia under us, and then he finished his FNB cardiac anesthesia. Right now he is a consultant cardiac anesthetist in Apollo Hospital, Madurai. Welcome, Rikesh. So the session is like this. We have two sessions. The first session will be mitral stenosis general considerations. That means mitral stenosis patient for non-cardiac surgery and cardiac surgery. And the second session will be pregnancy with mitral stenosis, which is a very common exam question. So we'll start with the case presentation. And now I ask Dr. Praveena and Ramya to start with their case presentation. And Rikesh and Chaitanya, both of you can ask questions. Over to you, Ramya and Praveena, and the model.
Yes, thank you. Morning, sir. A 47-year-old male, Mr. Govindan, from Parvatipuram, who is a shopkeeper by occupation, came to the OPD with chief complaints of difficulty in breathing for the past 1 week and chest pain for the past 1 week. History of presenting illness. The patient was apparently normal before 1 week, after which he developed difficulty in breathing for a duration of 1 week, which was gradual in onset, progressive in nature, aggravated by exertion, associated with chest pain, and it is relieved by medication. It was also associated with orthopnea and paroxysmal nocturnal dyspnea. History of chest pain for the past 1 week, progressive in nature, retrosternal, intermittent, moderate to severe, not radiating, not associated with palpitations, and aggravated by exertion and relieved by medication. No history of palpitations, no history of cough with expectoration, no history of syncope, no history of EC fatigability, no history of abdominal pain or abdominal distension, no history of swelling of legs, no history of fever, no history of oliguria or puffiness of face, no history of hoarseness of voice, no history of weakness of limbs, no history of loss of consciousness. Past history, history of fever with joint pain at the age of 7 years and diagnosed as having rheumatic fever and took treatment for that episode. No history of systemic hypertension, diabetes, tuberculosis, bronchial asthma or epilepsy. No history of any surgery in the past. Treatment history, patient is on tablet penicillin 250 mg OD, on tablet Lasix 10 mg OD, on tablet metoprolol 25 mg OD. Personal history, the patient is a non-vegetarian, chronic smoker and occasional alcoholic. Family history, no history of similar complaints among the family members. Summary, a 46-year-old male, a chronic smoker and alcoholic, came with complaints of dyspnea on exertion associated with orthopnea and paroxysmal nocturnal dyspnea with similar complaints in the past. The system involved is cardiovascular system. General examination, the patient.
Dr. Rikesh, you want to ask some questions here? Shall we stop here and ask some questions related to the issue?
I'll ask at the end, sir.
Okay. Proceed.
General examination, the patient is comfortable at rest, conscious, oriented, afebrile, moderately built and moderately nourished, not anemic, not jaundice, no cyanosis, no clubbing, no pedal edema, no significant lymphadenopathy. Vitals, pulse rate 84 per minute, regular rhythm, low volume, no specific character, no radial delay and no radiofemoral delay, no vessel wall thickening, felt equally in all peripheral pulses. Blood pressure, upper right limb, 103 for 70 millimeter of mercury in sitting position, 110 70 millimeter of mercury in supine position, respiratory rate 18 per minute regular, temperature 37 degrees Celsius and JVP elevated. Examination of cardiovascular system, inspection, chest wall is symmetrical, no chest wall and spine abnormalities like kyphosis and scoliosis. Apical impulse is seen in the left fifth intercostal space 1 centimeter medial to the midclavicular line. Trachea appears to be in midline. No precordial bulge, no visible pulsations, no scars or dilated veins. Palpation, not warm, not tender. Apical impulse felt in the left fifth intercostal space 1 centimeter medial to the midclavicular line. Tapping in nature, a thrill is palpable in the mitral area. Left side parasternal heave present. P2 is palpable in the pulmonary area and trachea is confirmed to be in midline. Percussion, right heart border corresponds to the right border of sternum. Left border corresponds to apical impulse. Liver dullness felt in the left fifth intercostal space. Auscultation, mitral area, S1 is loud, S2 heard, a low-pitched, rough, rumbling, mid-diastolic murmur of grade 4 with opening snap and pre-systolic accentuation heard in the mitral area with the bell of the stethoscope with the patient in the left lateral position at end expiration. Tricuspid area, S1, S2 heard, no added sounds. Pulmonary area, loud P2 present. And aortic area, S1, S2 heard, no murmur or no added sounds. Other system examination, respiratory system, normal vesicular breath sounds, no added sounds. GAT, normal bowel sounds, no organomegaly or no free fluid. CNS, no focal neurological deficit. So it is a case of acquired valvular heart disease, mitral stenosis with pulmonary hypertension, probably of rheumatic etiology. The patient is in normal sinus rhythm and with no signs of heart failure.
Yeah, Rikesh and Dr. Chaitanya, I can start with the question.
Okay. My first question is, your patient is having complaints of breathlessness for past 1 week, then associated with chest pain. What might be the cause for chest pain in this patient?
Patient may go for pulmonary hypertension, sir.
Okay.
So then pulmonary hypertension, right ventricular dysfunction. So right ventricular ischemia may happen, sir. So patient may have chest pain and dyspnea symptoms may be due to increasing left atrial size and left atrial enlargement. So increased left atrial pressure causing the pulmonary venous congestion and pulmonary arterial hypertension.
No. I want only one answer. What is the cause for chest pain in this patient? Left
pulmonary hypertension.
Yeah, pulmonary hypertension and right ventricular strain. Because of pulmonary hypertension, there may be right heart will be struggling to pump against high afterload. Okay. And with your history itself, you told you came to the conclusion of cardiovascular system.
Yes, sir.
Okay, why not respiratory system? He's a chronic smoker, could be COPD. What made you come to the conclusion of cardiovascular system just with history?
Patient already have the history of the rheumatic fever, sir, at the 14 years of age, and also the similar complaints in the past, sir. And here the main complaints is breathlessness, sir, not associated with any cough with expectation, sir. Okay.
Dyspnea is followed by dyspnea is present initially, sir. Whereas in case of any respiratory disease, initially cough and expectoration will be there, followed by dyspnea. And
now case
dyspnea was the presenting complaint, sir.
Okay. Another important thing is orthopnea and PND. That itself will
orthopnea.
Usually rule out respiratory system. Rajesh, sir, I have a doubt. Rajesh, sir?
Yeah.
Can I give my suggestions also, or
Yeah,
do
you
it
can.
at last?
You can.
Okay. You told the patient is not in heart failure at the conclusion, right?
Yes.
what does orthopnea and PND indicate?
Sign of left ventricular failure, sir.
So
Yes,
that has,
failure symptoms.
there are early signs of failure.
Failure.
Yes,
Yes.
You should adjust it. And you told patient is on medication, which this breathlessness was relieved with medication.
Yes, sir.
Yes.
Okay, what medication did you take history? Did you take history? Which medication relieved his breathlessness?
Diuretics, sir.
So he was recently started on diuretics.
Diuretics, sir. Yes.
Okay. You told history of rheumatic fever is there, right?
Yes, sir.
What is the criteria for diagnosing a patient with rheumatic heart disease based on the history?
So we have the Duckett-Jones criteria, sir. We have 5 major criteria. Major criteria includes carditis, pancarditis, migratory polyarthritis, Sydenham's chorea, subcutaneous nodules, and erythema marginatum. And we also have 5 minor criteria, includes carditis, arthralgia, and ESR more than 60, and CRP more than 30, and
Past history of
rheumatic fever. Along with this, evidence of positive streptococcal infection and ASO titer more than 300. From this criteria, if there is any 2 major criteria or 1 major plus 2 minor criteria, and the recent guidelines also shows any 3 minor criteria can be considered as positive for rheumatic fever, sir.
Okay. What is the most common valve involved in case of rheumatic heart disease, and what is the lesion? Because I asked you about rheumatic heart disease, I'm asking, which is the most common valve involved?
Mitral valve, sir.
Yes. And what could be the differential diagnosis for this patient? What are the differential diagnoses you want to put for this patient apart from mitral stenosis? Sorry? Okay, there could be a coexisting ischemic heart disease. So patients over 40 years and who is a chronic smoker, they are prone for ischemic heart disease because chest pain and breathlessness and with signs of early signs of heart failure that comes into criteria of coronary artery disease also.
Okay.
And how will diuretics help in reducing the symptoms of breathlessness? You told patient is on diuretics. He was started on diuretics, with which his symptoms improved, right? So how will diuretics help? Or if diuretic, first you tell me, how will diuretics help in relieving his breathlessness?
Decreasing the water retention, sir, is the main pathology behind the using the diuretics in the failures, sir.
Okay. So patient with mild mitral stenosis, mild or moderate, when will we have symptoms of breathlessness or like chest pain? He may be a patient of mild, moderate, or severe mitral stenosis. But when will a patient of mild mitral stenosis have the symptoms which you mentioned? When can it happen?
So when the disease, even though is mild, the patient, if the symptoms of left atrial pressure, if left atrial pressure increases, then he can have the following symptoms like orthopnea and paroxysmal nocturnal dyspnea, sir.
Okay. No, I'm asking, the patient is having breathlessness, right?
Yes, sir.
This patient you didn't do echo as of now.
No.
Yes, sir.
So he may be a case of mild mitral stenosis, he may be a case of moderate mitral stenosis, it may be a case of severe mitral stenosis with all the complications like pulmonary hypertension, RV failure, all. But when will a patient of mild or moderate mitral stenosis develop symptoms?
Sir, if since mitral stenosis is a fixed cardiac output state, sir, the myocardium won't be able to supply if there is going to be any increased metabolic demands by the body, or if there is going to be any fluid like blood volume, if it is increased, then the LV won't be able to cope up with the fixed, won't be able to cope up with the stress. And since it's a fixed cardiac output state, the patient may deteriorate and have the following symptoms, sir.
Even with mild or moderate. Yes.
Even with mild or moderate disease.
So tell me examples when it can happen like this.
Metabolic demands during fever, exercise, pregnancy, all these conditions, the metabolic demand may increase, sir. Whereas the blood volume, it will also, especially in pregnancy, and in this patient, that is when the left as such, when the pathophysiology develops, he might progress to symptoms, sir.
Yes, good. So this case of patients of mild mitral stenosis, they won't present you as a case of mild breathlessness or something. Only there should be some factor which will stimulate them to develop these symptoms, like you told, fever, pregnancy, all those things.
Infections.
Yes, where the cardiac circulatory overload will be high and heart will be struggling.
Yes, sir.
So why you told a lot of negative history in your examination, in your history taking? Can you tell me why you took so much of negative history for each? Can you put that slide where
Yes,
you
sir.
took a lot of? Especially in this patient, why this much of negative history is important? Can you put that slide? I want you to put that.
I already displayed it, sir. It's not visible, sir.
No, I'm not able to see.
1 minute, sir.
Yeah. So why did you take history of palpitations in this patient? I'm retrospectively asking. What could, if patient would have got palpitation, what would it suggest?
Patient may gone for any thromboembolic episodes or any arrhythmic events, sir.
Yeah,
So
arrhythmic.
gone for palpitations.
Don't come it as thromboembolic. It could be some arrhythmias. Cough with expectoration. Then if palpitations are there, then it is like which chamber is involved? RA, RV, LA?
LA, sir.
Yeah, due to
Left
left
atrial.
atrial enlargement, patient is prone for
arrhythmias.
atrial fibrillation and palpitation. Cough with expectoration.
When there is left atrial enlargement, sir,
Yes.
usually there will be impeding of the venous drainage, sir. So this will lead
Yes.
to pulmonary hypertension, sir.
Yes.
So pulmonary congestion and pulmonary edema. Okay, this may predispose the patient to the orthopnea, dyspnea, and also the cough, sir.
Okay. So if a patient is a case of chronic mitral stenosis, like he is with mitral stenosis on medicine for a longer time, maybe or 3 or 4 years, then is he prone for pulmonary edema?
Sir, in acute left atrial failure, the patient is more prone for pulmonary edema, sir. Or
Yes.
else acutely he won't develop pulmonary edema due to the increased left atrial pressure. The other changes in the pulmonary vasculature, like the pulmonary hypertension, and indeed that will promote the right ventricular hypertrophy. He'll have signs like that, sir. Acute pulmonary edema is precipitated when the patient has increase in acute left atrial pressure increase. Only he'll have, sir.
Okay. As the disease progresses, his vasculature will become adjusted to this thing, intimal hypertrophy will happen.
Yes, sir.
And they're relatively resistant to pulmonary edema. Then
Yes,
they
sir.
will start presenting with features of right heart failure.
Right heart failure, sir.
Okay. And why syncope?
Sir, since it's a fixed cardiac output state, sir, the patient can go in for syncope when he during exertion. When the output is reduced, he can go in for syncope due to the transient loss of decreased supply to the brain, and no issue of EC fatigability. The fatigability is also due to the reduced cardiac output status, sir.
Okay. Yes. case cancel. Okay, so syncope and easy fatigability may be due to low cardiac output.
Cardiac output state, sir.
So what I am very specific about this negative history because this will tell you at which level the disease has progressed. That is the reason why I'm asking you very specific about this. Why abdominal pain, abdominal distension?
Right heart failure, sir. So signs of the right heart failure, swelling of like speed, edema, abdominal pain, and abdominal distension are right heart failure symptoms, sir. So to rule out right heart failure, I'm asking this negative history and this history.
Fever.
Fever to rule out any history of infective endocarditis associated with the infective endocarditis, sir. So to rule out that fever is, or any history of recurrent of episodes of rheumatic fever also, we can ask for a fever history, sir.
Oliguria and puffiness of face.
That's the right heart failure symptoms, sir. Decreased urine output and edema will be there, sir.
Okay. Why hoarseness of voice?
And there's a syndrome called Ortner syndrome, sir. Due to left atrial enlargement, there is a compression of the recurrent laryngeal nerve, sir, on the left side.
Okay. Okay.
And history of LOC to rule out transient ischemic attacks, sir. So due to fixed
Anything
cardiac
else?
output,
For
Anything
weakness
else?
of limbs, it is due to the thromboembolic
episodes,
manifestations, sir.
thromboembolic events.
Why can thromboembolic event happen in case of mitral stenosis?
When there is a left atrial enlargement, there may be atrial fibrillation, sir. When there is an embolus or thrombus in the left atrium, it can dislodge to the cerebral circulation, sir.
Okay. What is the most common site of clot in left atrium?
Appendages, left atrial appendages.
Yeah, left atrial appendage. That is the most common site. And once the patient develops atrial fibrillation, they are more prone for development of this
Thromboembolic manifestations.
Yeah. So now coming to clinical findings. Show me the slide of auscultation. Yeah. Can you tell me why this murmurs are happening? Why this murmur is happening? Why the S1 is loud?
Mean diastolic pressure gradient is increased, sir.
Okay.
Actually, since there is a stenosis, sir, there is going to be a development of the transvalvular pressure gradient in order to push the blood from the left atrium to the left ventricle, sir. So what happens is, sir, during there will be a wide excursion of the mitral valve leaflets, sir. So when due to the increased transvalvular pressure gradient and during the early part of the ventricular systole, when the ventricle systole, the point where the mitral valve has to close. At that time, there is since the leaflets are in wide excursion, they has to close from distance, and hence they will close rapidly, or that will produce the loud S1, sir.
Okay. Next slide. What does that loud P2 indicate here?
Pulmonary hypertension, sir. Patient in pulmonary hypertension.
Okay. See, there are a lot of medical questions which they can ask you here. I don't want to concentrate much on that. Let's move to anesthesia, because in exam that is all theoretical.
Okay,
like
sir.
presystolic accentuation, opening snap, all those things you have to find know the cause of all those things. Mitral phasis mechanism,
Yes, sir.
all those things. So now, so you came to the conclusion that patient is a case of mitral stenosis with pulmonary hypertension with signs of early heart failure due to this thing. Now, can you tell me if this patient comes for some emergency surgery?
Rikesh, 1 minute. Chaitanya, do you want to ask some questions related to the history? Chaitanya.
Yeah, your patient had predominant chest pain, more than dyspnea. And age is how much you told?
46 years, ma'am.
Yeah. So what could be your first differential diagnosis?
Ischemic heart
Pain and
disease.
dyspnea.
Ischemic heart disease, ma'am.
Yeah.
Probably
First you think of ischemic heart
ischemic heart
disease.
disease.
Yeah, and around 25 to 30% cases of MSR have coexisting ischemic heart disease as well. And the rheumatic process itself can affect the left ventricle and myocardium and there is some amount of fibrosis and ischemic changes might be there associated with the pneumatic process itself. Okay, and in your negative history, what else have you missed something? Commonly asked in the examination. They are interested in one term along with the expectation.
Hemoptysis.
Yeah, they generally ask this question: what are the causes of hemoptysis?
Yes, ma'am.
What are the causes?
Pulmonary apoplexy, ma'am. Due to pulmonary hypertension, there will be rupture of the bronchial veins, or if there is associated pulmonary hemosiderosis, pulmonary infarction, or winter pneumonia, or use of anticoagulants in the mitral stenosis. Patient may itself predispose the patient for hemoptysis.
Yeah, because the pulmonary system is in under high pressure, and at the same time, systemic circulation is at lower pressure. So when there are the shunts developed, even with the mild increase in left atrial pressure, or whenever patient coughs, because of the shunts between high and low pressure, there may be rupture of this channel. So there may be hemoptysis and other reasons like hemochromatosis, or it could be kind of pulmonary edema as well. Things for this symptom like that. That has to be told in the negative history about history of hemoptysis. Okay, go ahead.
Rikesh, you can start with your questions. Okay. Rikesh?
Sorry, I mute.
Yeah, you can.
Okay, if this patient comes for some emergency surgery, the same patient comes for some emergency surgery, so how will you proceed? What all investigations do you need?
First, I asked for the history, sir. History
Okay.
of
No, history you have taken. You have come to some conclusion that this is a case of probable mitral stenosis with pulmonary hypertension. Then he comes with actively bleeding hemorrhoids. Okay.
So I will ask for CBC, sir. First, routine investigation. I will go with routine investigation such as CBC, sir, to rule out any anemia, sir, and then TCTC count, sir, for any to rule out any history of fevers in presently is presented with fever or not, sir, and then blood glucose level and serum electrolytes to rule out any dyselectrolemia, sir. So this
why electrolytes? I didn't get you.
So, high risk for perioperative arrhythmia in this case.
Sir, and the patient is on diuretics and
if the patient is on digoxin, also as per electrolytes.
Yes, he's on diuretics, right?
Diuretics and digoxin.
So there can be he's on metoprolol, I think.
Yes, sir, metoprolol. If the patient is on diuretics and digoxin, we are more concerned about the serum electrolytes.
Why is very specific for digoxin?
Hyperkalemia can occur due to the administration of digoxin, sir. And in hypokalemia, the digoxin, the patient is more prone for digoxin toxicity also. So we have to monitor the potassium levels, sir.
Okay. So next. That's it.
Biodation profile, I mean, for this patient, sir.
Okay.
This is the routine blood investigation, sir, and ECG and chest X-ray, sir. And this is an emergency, so I can't ask for an emergency echo, sir.
Echo, you can do it within 5 minutes if your hospital have it.
Okay.
To confirm, because without confirming the diagnosis, you cannot proceed.
Yes.
Okay. So if it will take lesser time than shifting the patient for an X-ray or ECG. It will hardly take 5 minutes. So echo should be included. No?
Okay.
Okay. Then what all changes you will find in ECG for this patient? What do you expect?
P mitral, sir.
What is it? What is P mitral?
So in lead 2, there will be bifid P waves, sir.
Okay. Why?
Due to the right atrial enlargement, sir.
Okay. Then?
And signs of right ventricular hypertrophy, sir. So right axis deviation is there or not? And to rule out AF, I can see the rhythm, sir, or if there is an absent P wave or irregular rhythm. So to rule out AF, ECGs must, sir.
Then?
So in chest X-ray, mitral stenosis evidence of the splaying of the carina, sir. If there is left atrial enlargement, atrium within atrium, that is double atrial shadow, I can see, sir, and Kerley A lines and Kerley B lines, sir. And if prominence of pulmonary veins in the upper lobe, sir, this leads to antler signs. And left straightening of the left heart border will be this.
Okay, why does this straightening happens?
So usually the pulmonary bay will be concave, sir, but in the patient go for pulmonary hypertension, mitral stenosis, the pulmonary bay become convex, and this leads to the straightening of the left heart borders.
And aortic knuckle also will be aortic knuckle also due to the fixed cardiac output or the low cardiac output status. The aortic knuckle will be drawn inwards, sir. The pulmonary bay will be prominent because of the increased pulmonary arterial hypertension. And there is also going to be the left atrial appendage also, it will become prominent, sir. So hence there will be a straightening of left heart border, sir.
Okay. And left ventricle also can be atrophied or shrunken.
Okay, sir.
Okay. And they did an echo. So they told this is a patient of moderate MS.
Yes, yes.
So how will you grade mitral stenosis after seeing an echo?
Seeing the mitral valve area, sir. More than 1, it's mild, sir. More than 1.5 is mild, sir. 1 to 1.5 is moderate, sir. When the mitral area decreases to less than 1, it is severe, sir. And also the diastolic pressure gradient, sir. If it is less than 5, it is mild. 5 to 10, moderate. More than 10, it's severe, sir. And then pulmonary artery pressure, we can grade into. If there is mild, there is a less than 30 mm mercury, sir. In moderate, 30 to 50, sir. In severe, more than 50, sir.
Sorry, I didn't get you. Tell me again.
Pulmonary artery pressure, sir. Less than 30, it is mild, sir. 30 to 50, it is moderate. And when it goes more than 50, it is severe, sir.
Which pulmonary artery pressure? Systolic, diastolic, mean?
Mean
pulmonary artery pressures.
Okay. Are you sure?
Systolic pressure, sir.
Okay. See, I want to tell you one thing.
Okay. Another score called Wilkins score, sir. Mitral.
Rikesh, you have to unmute. Rikesh?
Sir, sorry, sir. Someone came to hospital. That's the.
Okay.
See, there is when I ask you about mitral stenosis, don't gradation of mitral stenosis, don't tell me about pulmonary hypertension. Okay, when you told mild mitral stenosis, it is 1.5 centimeters square. Okay, 1.5 to 4, 1.5 to 6. What is the normal mitral valve area? So
4 to 6 centimeters square, sir.
That is normal.
Yes.
Okay, when will the patient start developing symptoms?
1.5 to 2.5, and the patient is in fever, exercise, that is a high metabolic state, patients develop symptoms, sir. When the area decreases less than 1, and the symptoms usually occur at rest also, sir.
Okay. What about this gradient you told?
Mean pressure gradient, sir. Less than 5, 5 to 10, more than 10, sir.
Okay.
And there is another score called Wilkins score, sir, based on the 4 parameters: valve leaflet thickening, calcification, sir, mobility, and suborbital calcification, sir.
Okay. How Wilkinson score will help us in this case? You tell me.
If the patient goes for percutaneous transmitral commissurotomy, sir, it will predict the outcome of the patient, sir.
Okay, I didn't ask you about that, right? I was asking about this patient for emergency hemorrhoidectomy. Okay.
Okay.
So what all you will specifically ask for in echo, apart from this gradation of mitral stenosis, what all will you specifically ask?
So from echo in 2D B mode echocardiogram, we can see about the diastolic dooming. We can grade the severity of mitral stenosis using the valve area. And we can also see the left atrial dimensions, and we can also rule out if, any presence or thrombus in the left atrium, sir. And in case of with the Doppler flow only, we will be able to assess the transvalvular pressure gradient, and also the transvalvular flow and pulmonary hypertension grading can be done using the Doppler flow, sir. Whereas in case of M mode, we can see the mobility of the leaflets, whether there is any thickening or not, and calcification can be seen using the M mode, sir.
Okay. No, anything else apart from mitral valve you want to see? I'm asking. In echo.
Sir, from echocardiography, ejection fraction also I would want to know, sir.
So what do you expect in ejection fraction? It will be a normal, decreased, or increased?
Mitral stenosis, mitral contractility will be normal only, sir.
Okay. What will you do if there is fall in ejection fraction? Suppose ejection fraction is 40%, global hypokinesia. Can it happen in a case of mitral stenosis?
Yes, sir.
Due to mitral valve?
Yes, sir. It may happen, sir. When left ventricle dysfunction due to decreased filling of the left ventricle, if the left ventricle goes for atrophy, muscle can go for atrophy, sir.
Okay.
That time left ventricle contractility get compromised, sir.
Okay.
That time left ventricle dysfunction can happen, sir.
Okay. If there is any regional wall motion, if anterior wall hypokinetic with LVEF of 40%, it's not a global hypokinesia. If it is a regional wall normality,
then I would suspect of any ischemic heart disease, associated ischemic heart disease for this patient, sir.
okay. Then what else? Ejection fraction. Then what all will you see more?
So
Left atrial appendage would you like to see?
Yes, the
Any
left
clot or
atrial
thrombus,
dimensions
sir,
and any presence of
clot
thrombus.
Clot or thrombus.
Okay. Left atrial size.
Yes, sir. Yes,
Yes, sir.
left atrial dimensions.
Okay. The more the size of left atrium, the more he is prone for thrombus and arrhythmias. Okay. And RV function, is it important in this patient or no?
Yes. Yes, sir. Important. Pulmonary
Okay.
hypertension, patient with pulmonary hypertension.
So how will you? So this is a bit higher end question I'm asking you because you're answering well. So how will you measure pulmonary pressure at echo? Usually you will require SWAN to measure pulmonary artery pressure, right?
Yes, sir.
So how will you measure it in echo? Do you know?
So we have to see the pressure half time. We have to see, sir.
No, pulmonary hypertension I'm asking. PA pressure, pulmonary artery pressure. So you should measure tricuspid regurgitation. The patient, to measure a pulmonary artery pressure, patient should have some tricuspid regurgitation.
Okay, sir.
So by tracing that tricuspid regurgitation, you will get to idea of pulmonary artery pressure. Okay, based on that only you can tell. Okay.
Yes, okay.
Okay. So patient is a case of. So patient is a case of mitral stenosis with pulmonary hypertension with RV dysfunction. So what anesthesia would you like to give for this patient?
Rikesh, can I ask one small question?
Yes, sir. Yes, sir, please.
They mentioned about the pressure half time. What is pressure half time and what is its importance in mitral stenosis?
The pressure half time will tells us about, we'll give an idea about.
I wanted to know from the postgraduates, Rikesh.
Okay,
they know the significance of pressure half time.
Okay, sir.
So pressure time taken for the gradient, the pressure gradient across the mitral wall to decay to its half of its peak value, sir. So from here we can assess the mitral wall area also, sir. Mitral wall area is equal to 220 by pressure half time, sir.
And pressure of time is also used for the grading, to grade the severity of mitral stenosis, sir. In mild, it will be around 140 to less than 140, sir. In moderate, 140 to 220 milliseconds, and if it is more than 220 milliseconds, it indicates a severe disease, sir.
Yeah, very good. Okay.
Okay. It is the other way to tell, like, because pressure 220 by pressure half time gives us the mitral valve area.
Yes, sir.
Okay, so you did not tell this pressure half time for grading the severity because it will obviously come in this valve area. Okay. Okay. Then how will you induce? What is your choice of anesthesia for this patient? And what all monitoring do you require? Sir, I have another 10 minutes, right? Rajesh, sir?
Yeah, you can proceed. You have to.
Okay. What all monitoring do you require for this patient?
The standard ASA monitors, sir. First ECG, NABP, and saturation, sir, and ETCO2 and temperature probe, sir. And this is the case of the mitral stenosis, sir. So special hemodynamic monitoring, I may ask for T, sir. And sorry, then the major surgery cases, T.
No, why T is normal echo? Isn't it enough? Because you are not operating on the chest, right?
Yes, sir.
So normal echo will be enough.
Okay.
Yes, sir.
Okay. TE, if they're operating on abdomen or chest or something, then you can use TE. Anything else? Arterial line do you require or no?
Arterial line, sir. If there is major fluid shift, sir. So B to B variability. I have
Major fluid shifts can happen in hemorrhoids surgery. I told you, no, it's a case.
Yes, sir. No, sir. So no need of any invasive monitoring, sir. Since
it's a case of hemorrhoids.
So you don't require arterial line. See, don't get confused. I am asking. If you tell you need arterial line also, it's correct. If you tell if you don't need also, it is acceptable, but you have to justify why you need or why you don't need. It is, I am for arterial line.
So since it's a case of mitral stenosis associated with pulmonary hypertension, I would like to go for invasive monitoring, sir, like arterial line.
Okay. So, for placing an arterial line, the type of surgery doesn't matter. Okay, it may be a minor surgery, it may be just 5 minutes or 10 minutes procedure, but you are giving anesthesia, na?
Yes,
That will cause a lot of hemodynamic changes in the patient.
Yes,
So for that you need an arterial line.
okay, sir.
Okay, then do you want central line for this patient?
No need, sir.
No, sir.
Yes, central line is not needed. So how will you induce this patient for anesthesia? So what is your choice, general or regional?
Sir, I go for general anesthesia, sir.
Okay. Why?
In case the
Why
mitral
general? Why
stenosis-
not regional?
The mitral stenosis is associated pulmonary hypertension, sir.
Okay.
And also the impeding signs of the failure is there, sir.
Sorry, I didn't get you.
Failure symptoms are there, sir. So if any post-op respiratory problems occurs, I will manage with ventilation, sir. That's why I prefer
Okay.
GA in this case, sir.
Okay. See, I'm telling about isolated pulmonary hypertension. Okay. In case of isolated pulmonary hypertension, leave about mitral. You are again and again telling about pulmonary hypertension. That's why I'm telling. In case of pulmonary hypertension, there will be rise in pulmonary artery pressure if you use GA, if you give GA. So in them, especially regional anesthesia will be preferred. But here, as there's a case of MS, severe MS with pulmonary hypertension, spinal may cause problems. So graded epidural can be given,
Rated epidural.
or GA is always safe.
Okay, sir.
Okay.
Okay.
See, I am not doing cardiac anesthesia, general anesthesia, but this is a suggestion. Okay. So if you want to go ahead with general anesthesia, so you tell me what induction agents do you use?
So first, my hemodynamic goal is to avoid tachycardia, sir. So maintain adequate afterload and controlled ventricular response, sir.
No, you tell me again what?
So my main goal is to avoid tachycardia, sir. Tachycardia
Okay.
and maintain adequate afterload and payload, sir. And I have to maintain the controlled ventricular response, sir. So for induction, during induction, to anti-anesthetics, sedatives like midazolam, sir, I will go with midazolam 0.15 mg per kg, sir, to elevate, to blunt the stress.
1 minute. I want to obstruct here. See, first of all, if I ask you hemodynamic goals of anesthesia, you should start with preload, afterload,
contractility,
heart rate, contractility,
and
pulmonary
pulmonary
vascular
vascular resistance, avoid hypoxia, hypercarbia, acidosis.
Okay. When can this happen in case of GA or regional anesthesia? Pulmonary hypertension. You asking about PVR, no?
Yes, sir.
Yes, sir.
General
When can
anesthesia.
the, yeah, that is the reason why I told you. Okay. Then what about preload? You should maintain preload, or you should.
We should
Maintain
maintain
our
adequate
preload, sir.
preload,
Adequate
sir.
preload, sir.
Can you allow hypovolemia?
No, sir.
No, sir.
Adequate preload has to be maintained and adequate afterload also has to be maintained, sir. Any decrease in systemic vascular resistance, any decrease in SVR also is not tolerated by the patient, sir. So we have to maintain the adequate preload, adequate afterload, and we should also maintain the adequate contractility. And in order to avoid the increase in pulmonary vascular resistance.
What is maintaining adequate contractility? See, preload and afterload, they are very sensitive to low preload and low afterload. They can tolerate even higher preload and higher afterload. Okay, but they're very sensitive to low preload and low afterload. Now you told something about contractility. What is maintaining contractility, or what is decreasing contractility, and what is increasing contractility? Why do you want to decrease contractility, or why do you want to increase contractility, or why do you want to maintain contractility? You told you want to maintain, right?
Yes, sir.
Why you committed that word, maintain contractility?
So we should not give any cardiodepressant drugs, sir. And
like.
So mainly, we should avoid inhalation agent. Halothane should be avoided, sir. It has the arrhythmogenic potential, sir.
Okay.
So I would avoid halothane, sir.
Okay. So whether any of your drugs increase cardiac contractility?
Ketamine can increase.
Digoxin can increase.
No, anesthetic agents.
Ketamine can increase, sir.
Okay. Here you should tell for contractility, avoid increase in contractility.
Yes, sir.
Why? Because it is not about contraction. Be very clear. It is not about contraction. All the drugs which increase contractility will invariably increase the heart rate.
Heart rate, sir. It will produce tachycardia.
Which is very detrimental for this patient.
Yes, sir.
That is the reason why you have to avoid increase in contractility. If there is any wonder drug which won't increase heart rate and only improve contractility, that's not bad. That's not a bad idea. But there won't be any increase in cardiac output with that because it's a fixed cardiac output state.
Okay.
Then heart rate, it should be low or it should be high or it should be. Which do you prefer, lower heart rate or higher heart rate?
Normal or lower, sir.
Low to normal
higher heart rate,
sir.
Yes. Higher tachycardia should be avoided at any cost.
Yes.
Okay. So you will go ahead with general anesthesia.
Yes.
Then what else? So the patient will be placed in lithotomy position, right?
Yes.
So is there any precaution needed, or you can just once you induce anesthesia, you'll ask them to go for.
So we should oxygen supplementation, sir.
General anesthesia anyway you are giving, no?
So during lithotomy position, we should be very careful, sir, because during that position, there is going to be a sudden increase in the venous return, and which the patient won't be able to cope up, sir. So the position has to be done in a very gradual manner, sir. The sudden the extension of the leg should not be done. It should be done in a very gradual manner, sir.
Okay, good, very good. And this is very important when you are giving regional anesthesia for these kind of patients. General anesthesia, anyway, pulmonary edema can't happen, but there can be rise in pulmonary artery pressure and all those. Okay. Even while extubation also. Tell me what precautions do you take while extubating the patient, and what are intra-analgesia, adequate intra-op analgesia, depth of anesthesia should be adequate.
Yes, sir.
Then post-op you opt for ventilation, or you can extubate on table.
You can extubate the patient on table, sir.
Okay. Here is where you can do an echo to see if there is any right ventricular dysfunction or something with after anesthesia. Pulmonary hypertension may be high, right, after inducing general anesthesia. So RV may go for acute failure. If there is nothing, here is where your echo will help, either TE or transthoracic echo.
Okay.
Okay. So you'll extubate in a pain-free state.
Yes, sir.
No need to
Adequate
send the patient
anesthesia.
for, no need to send the patient for post-op ventilation.
Yes, sir.
So, have you seen cardiac surgeries?
No, sir.
Mitral valve replacement and all?
No, sir.
Give me a minute. Rajesh, sir?
You can start your slide screen.
Sir, shall I give them a small idea because they have
Yeah,
haven't
you
seen cardiac
can
surgery?
proceed. You can proceed with the slide.
Sir, okay. Sir, will you share this PowerPoint I sent you yesterday?
Yeah, 1 minute, 1 minute.
Sir, I forgot to ask about pressure volume loops, but I will tell them. Yes,
Okay,
in the
sir.
PowerPoint itself, it is there. That,
Okay.
pressure volume loop.
Can you see something there?
No, sir, not yet.
Yeah, 1 minute.
A quick question in between now. You told about the classification of mitral stenosis based on the valve area, right?
Yes, sir.
On what clinical criteria is that valve area interval determined?
Sir, what's that?
This is progression.
On what clinical criteria was that valve area determined?
Based on,
shall I-
sir, his breathlessness, sir, based on dyspnea, sir.
Okay. 1 minute. I'll just share my screen. 1 minute. Are you able to see the screen?
Yes, sir.
Okay. See here, the normal area is 4 to 6 centimeters square. When it reduces to 2 centimeters square, what happens is at rest, the left atrial pressure, the PA pressure, and cardiac output, they remain normal. But when you exercise, your LA, PA, and cardiac output will actually increase. Okay. When it reduces less than 1.5, what happens is even at rest, the left atrial and PA pressures will be high, but the cardiac output will be normal. When you exercise, all these pressures will start rise, especially the LA pressure. When the valve area goes less than 1 centimeter square, what happens is even at rest, the left atrial pressure will be high, very, very high. And the cardiac output slowly starts reducing. When it becomes less than 0.8, that's called the critical point. This is when the tissue organ perfusion is compromised. So this is how they have given the class intervals as 2 to 1.6, 1.5 to 1.1, less than 1 and 1.8. Is it clear?
I asked, hello?
Sir, I'll share my screen. Then it
Yeah,
will...
you are sharing. Yeah, okay.
Can you see, sir?
Yeah, you
Yeah,
can
it is
start.
visible, yeah.
Should I hold on to this slide or should I move to the next, sir?
I will move it, ma'am. I will move it.
No.
This is yours. No, this is Rikesh, this is Guru Shanti. Yes, you can start, you can proceed here.
Okay, sir. No, I don't. Okay. Okay. Pathophysiology, anyway, they explained, sir. They already told all the changes that happen. See, in mitral stenosis, because it is online, you may not be able to draw, but
Okay,
pressure
sir.
volume loop will be shifted to left.
Okay. Yes, sir.
Hope you know what is a pressure volume loop.
Yes, sir.
Can you go to next slide, ma'am? It is for, yeah, pressure volume loop consists of 4 points, A, B,
Yes, sir.
C, and D.
Yes, sir.
So A is where aortic valve closes. Okay. And A to B is isovolumetric contraction.
Relaxation.
Hello.
Yeah, you can
Yes,
proceed with
you are
it.
audible, sir.
Yeah, you are audible.
Okay.
You are audible.
And B is where mitral valve opens.
Okay, sir.
Okay. See, there is no change in volume of the left ventricle from A to B. And B to C is where the blood flows from left atrium into the left ventricle. Okay. And
Okay.
C, mitral valve closes, and at D, aortic valve opens. So C to D is isovolumetric contraction.
Yes, sir.
Okay. And this volume is stroke volume. Okay. And it changes with different valvular pathologies, restrictive cardiomyopathy, and diastolic dysfunction. All those will have different patterns. In case of mitral stenosis, can you go back to previous slide now? See, in case of mitral stenosis, here the mitral valve closes early, that is point C.
Yes, sir.
Okay, so the stroke volume is less. Can you see?
Yes, sir. Yes, sir.
Okay, I'm not able to explain here.
Okay, sir.
Okay, this is basic thing. If you just go through it, it will be very easy. I'm not able to explain. Sorry.
Okay,
Okay,
sir.
man, go to next slide. Yeah. So coming to treatment, mitral valve usually will be managed medically with diuretics, digoxin, and rate control with beta blockers. So
Okay.
once the patient is having symptoms even with these medications, then the treatment options will be closed mitral valvotomy, PTMC, and mitral valve replacement. Closed mitral valvotomy is a surgical procedure which is almost obsolete now. Why? Because PTMC has taken over CMV.
Okay, sir. Okay,
The same procedure will be done by percutaneous method. So
Okay.
closed mitral valvotomy was once upon a time very famous procedure or very important procedure, which will help the patient in relieving of symptoms before mitral valve replacement even arrived.
Okay.
Then this PTMC has taken over the closed mitral valvotomy, but PTMC is not possible in all the patients.
Okay,
Why?
sir.
Because, like you told, there is a Wilkins criteria
Yes,
which
sir.
have various factors which will help in helping the success of PTMC. If the patient is having LA clot, PTMC is absolutely contraindicated because
Okay.
once you open the valve, the clot may get dislodged and it may cause some major stroke. Okay, PTMC or balloon mitral valvotomy, both are same.
Okay, sir.
Then this is done under cath lab procedure. It's a cath lab procedure where under angiographic and ultrasound guidance, echo guidance, they'll be dilating the mitral valve and see the gradient
Okay, sir.
and assess the successful PTMC result. The major problem with PTMC is once you overdilate the mitral valve because it is calcified, the patient may develop sudden MR and heart failure. So anesthesiologist is required to tackle those situation and intubate the patient, prevent the patient from going to pulmonary edema and low cardiac output state. It's a mess. If the patient develops MR, it's a bad problem, bad thing, and you have to lot of inotropes are needed. IABP may be needed. All those things. Okay, now coming to mitral valve replacement. See, I'm just giving a brief. Next slide now. So when the patient comes for a surgery for mitral valve replacement, first you have to confirm whether the diagnosis is correct based on transthoracic echo.
Okay.
So you do a TEE and confirm it is mitral stenosis.
Okay,
And you have to see other valves are involved like RV dysfunction, tricuspid regurgitation can happen. In TE, we have to find all these things.
Okay, sir.
And you will induce the patient with wide bore peripheral line and radial line, which will be placed under local
Adequate local
infiltration
anesthesia.
and standard induction for drugs. Because myocardial depression won't be of detrimental effect, I usually use thiopentone, sleeping dose of thiopentone. Etomidate is good enough. Propofol better to avoid because it is reduces SVR significantly.
Okay, sir.
Okay. My drugs are thiopentone, vicuronium, and fentanyl.
Yes, sir.
And I'll make sure that patient is adequately filled. Okay.
Yes, sir.
And any hypotension will be tackled with vasopressors, boluses, intermittent boluses of noradrenaline or phenylephrine. I'll avoid tachycardia and I'll maintain contractility. I won't give any inotropes will not be given to the patient in case of any hypotension or whatever it is. Okay. And ventilation with low tidal volumes and no PEEP at all. Okay. Any hypotension, we should correct it with vasopressors or fluids. Anyway, transesophageal echo is there. So you can assess the volume status and you correct it with fluids.
Okay, sir.
Okay. Next slide, ma'am. Next slide, ma'am.
1 minute, sir.
So once patient is induced and sternotomy is done, they require 400 units per kg of heparin to achieve activated clotting time of beyond 400 seconds.
Okay, sir.
This is for safe conduct of bypass so that the circuit won't be clotted. Patient should be fully heparinized.
Okay, sir.
Okay. Then aortic and venous cannulation will be done. And before going on bypass, you should make sure that patient is properly anesthetized.
Okay, sir.
Okay. And depth of anesthesia, analgesia. Patient will be under his heart and lungs won't function, but all other organs will be functioning and they'll be in hypothermia. So the dosage of drugs may be slightly less, but before going to cardiopulmonary bypass, make sure there'll be an adequate depth of anesthesia. So once the patient has gone for successful cardiopulmonary bypass, his heart will be arrested by instilling cardioplegia. Heart will be arrested in diastole and native mitral valve is excised. It can be done via LA or RA approach. Left atrium will be, if left atrium is enlarged, they'll prefer to open left atrium. If left atrium is small, it is like initial stage of severe mitral stenosis. They'll open RA, they'll open this interatrial septum, and then they'll approach the mitral valve. It appears complicated, but it is a better approach if LA is not enlarged. Understood?
Okay.
Okay. Then mitral valve annulus will be measured with different sizes, and prosthetic valve will be implanted after measuring the correct measurement of annulus, and chambers closed, and slowly patient will be rewarmed and heart activity returns. The patient will be gradually weaned from cardiopulmonary bypass. He requires some inotropes usually. Here now there is no problem of giving inotropes because valve has opened up. Okay. And during cardioplegia, heart would have become ischemia. Heart would have gone for ischemia or stunning. All those can happen during cardiopulmonary bypass because heart is arrested, right? Nearly for a period of 45 minutes to 1 hour.
Okay.
Even though you take adequate precautions like hypothermia, giving cardioplegia and all, they can happen. Okay. Next slide, sir. So there, you see, this is a brief introduction about prosthetic valve. There are two types of valves: prosthetic tissue and mechanical. First, you see about mechanical valves. Mechanical valves are relatively cheaper, right? And they last lifelong. Even they quote it for 100 years also, but they require long-term anticoagulation. Patient needs to come to hospital every month to check his INR value. It should not be high, it should not be low. It should be maintained. Therapeutic index is very narrow for this acetylcholine and warfarin. So they require frequent hospital visits for adequate dosage of acetylcholine.
Yes,
And because they are on acetylcholine, they are high risk of bleeding. Excuse me. They are at high risk of bleeding also, and they are at high risk of valve obstruction also. Because if the adequate anticoagulation is not given, there may be a valve may have thrombus and it may get struck. So more risk of bleeding also, more risk of sudden deterioration also due to struck valve. Okay, but lifelong. It is a lifelong procedure. But coming to tissue valves, they are very expensive. Okay, and they last for only 8 to 12 years. But still they're expensive because they are made from bovine or porcine pericardium. And there is no need for long-term anticoagulation. You need to anticoagulate this patient only for 3 months till the tissue get epithelialized, that valve get epithelialized. And so there is no need of frequent hospital visits. And so no need to maintain this INR value because there is no risk of bleeding. So that is why there is no risk of bleeding. That is the reason why tissue valves are more expensive. Even though their lifespan is only for 8 to 12 years, they are expensive.
Okay.
So this is the reasons for straightening of left heart border. That small aortic knob due to low cardiac output, and left atrial enlargement, and pulmonary venous hypertension. All those things what you told.
Okay.
And ECG, you can tell. Next slide is ECG, I think. Yeah. How will you tell the patient is in AF?
So absent P waves and irregular rhythms, sir.
Okay. Yeah, that's it. This is a classic picture of
Fibrillation.
atrial fibrillation. Okay.
Yes, sir.
That's it. Sir, I think Madam can start.
Before that, two questions. I think better we can answer it here itself.
Okay.
One question is related to percussion in cardiovascular system examination. Do we have to comment on that? This is a question from postgraduate.
Yes, sir. I was thinking to ask that question. Percussion nowadays has no role in this thing because you can hardly make it. The main thing with percussion is you can, especially in this patient, is you can tell whether there is a hepatomegaly, which is a sign of right heart failure.
Yes,
Because cardiac borders and all, it's not possible to measure. Or maybe we became sluggish nowadays over the last 10-15 years with the advent of echo and all those
technology.
Yes.
Okay. Another question is like high opioid induction in this type of patients coming for non-cardiac surgery, minor surgery, or intermediate risk surgery.
Sorry, sir, I didn't hear you.
Opioid induction for non-cardiac surgery.
Yes, sir. Opioid induction is very safe for this patient because it will reduce the heart rate also and no much effect on cardiac contractility. But the only problem is for a minor surgery, the extubation may be delayed. If it is a minor surgery like I told you, this hemorrhoids, that is the problem. Or else opioid induction can be given. Because it reduces heart rate also, it will be beneficial. But it is not mandatory that once upon a time it was like high opioid induction. That is, it is not mandatory for high opioid induction.
Okay, then we will move on to the second session.
Okay,
that is pregnancy with mitral stenosis, which is a very common clinical case discussion happening in every exam. So, Dr. Chaitanya, can we start with the case scenario and discuss?
Okay. So now we learned in the plain MS. Now superadded with the pregnant patient, superadded with the MS. So I'll start question. So what are the further the pregnancy changes? How they affect the pathophysiology of mitral stenosis? How it worsens the condition?
There are certain cardiovascular changes which occurs during pregnancy month. There is going to be a physiological increase in heart rate of 15 to 20%, and there will be an increase in stroke volume of 15 to 30%. And in overall, there is going to be an increase in cardiac output of 40 to 50%, ma'am. And also there will be a decrease in systemic vascular resistance of up to 15 to 20%. So hence all these changes added, the patient is already in, since the mitral stenosis patients, they won't be able to tolerate any high output state. since it's a fixed cardiac output state, ma'am. But pregnancy by itself will, it produces a high output state, ma'am. There is going to be increase in cardiac output, and tachycardia is also going to be there, ma'am.
So all these changes are exactly the opposite of your anesthetic goals. What you
Yes,
told.
yes, ma'am.
So all heart rate, you want to keep it lower side, it is increasing.
Yes,
You want to maintain SCR, it is falling.
yes,
You want to reduce PVR, it is increasing.
yes.
So all these things are exactly opposite of your anesthetic goals in MS patient.
Yes, ma'am.
Further, what happens during the labor?
Labor is the most vulnerable period, ma'am. During labor and the immediate postpartum period is the time where the patient will desaturate, where the cardiac compensation and pulmonary edema can occur. It is mainly due to the autotransfusion, ma'am. Immediately after delivery, there is going to be autotransfusion, and there is going to be flooding of the central circulation, which the patient won't be able to cope up, and hence they can develop pulmonary edema, ma'am.
Yeah. Further, due to labor pain, they have
Yes, ma'am. Labor pain, and at point also due to sympathetic stimulation, they are going to have further tachycardia will be more pronounced at that time, ma'am. So during the labor and the immediate postpartum is where the patient is more prone for decompensating, ma'am.
Yeah, they all do. There is labor pain and there is iopecal compression.
Yes, ma'am.
And also transfusion as well. Not only immediate postpartum, till up to
72 hours for postpartum.
Even a week, you can consider yes. High risk phase for
yes,
any MS patient post delivery.
Yes, ma'am.
Okay. Now I will give you a hypothetical situation. You tell me how will you go ahead in such cases. Okay. So around a 30-year-old patient with history of confirmed case of mitral stenosis with the valve area of around 1.3. Yeah, with mild dyspnea. Okay. And this thing around 18 weeks of pregnancy, 20 weeks of pregnancy. She is posted for cervical encephalopathy procedure.
Okay, ma'am.
So how will you evaluate and how will you go ahead?
From the history, I'm according to the valve area, the patient comes under the moderate category, but the patient, according to symptoms, she does not have any symptoms. She has only mild symptoms. Hence, I would, since it's a cervical for encerclage, I would like to go for a graded epidural. I would like to go for a graded epidural, ma'am.
Okay. Fine. The plan of management would be correct for this patient because you are considering fetal indications as well here. You want to avoid all the
fetal complications also I would like to avoid, which are in general anesthesia. Exposure to the anesthetic agents may also cause a fetal respiratory depression and all, ma'am. So I would like to go for the epidural.
Avoid polypharmacy in general anesthesia.
Yeah. Okay. Early pregnancy, you want to avoid all this stuff.
Yes,
okay? That's right. You want to go ahead with graded epidural.
Graded epidural.
Okay. So in pregnancy, as you told, it worsens the situation. What are the how can you optimize this patient? What are the options you have?
In pre-op optimization, already for the I have to see whether the patient is in. First, I would like to see whether the patient is in sinus rhythm, ma'am. If the patient has any associated complications of mitral stenosis, if she is going to have atrial fibrillation, I would like to optimize the patient first. I would maintain the sinus rate, ma'am. Then I will also advise the beta blockers, and I will see whether the patient is in volume overload state or if she has any signs of heart failure. And the volume overload status also has to be optimized pre-op, and any electrolyte imbalance should also be optimized pre-operatively, ma'am.
Can you tell me in detail about this medication? Which beta blockers you want?
Yes, ma'am. Beta blockers. In beta blockers, I would like to go for metoprolol, ma'am. Metoprolol, I would prefer metoprolol because since the administration of atenolol has caused intrauterine growth restriction, I would be more in favor of metoprolol, ma'am. And then for rate control, I will go for metoprolol. And also, I will go for if the patient is in atrial fibrillation, I will also administer digoxin along with beta blockers. And the first and foremost step is to avoid any further exertion. Our activity has to be decreased. Then beta blockers, diuretics, if in any volume overload status, furosemide can be given, ma'am. And digoxin if the patient is in atrial fibrillation, ma'am.
Yeah, beta blockers, you want to use selective beta blockers.
Yes,
Why you want to go ahead with selective beta blockers? Why not atenolol?
Yes, ma'am. Atenolol is said to cause IUGR, ma'am, intrauterine growth restriction due to the fetal.
Most of the beta blockers are associated, but this is more selective.
Yes,
when you continue during delivery or cesarean, the associated uterine relaxation is less with selective, because beta 1 selective, beta 2 uterine action also comes. Tocolysis may happen.
Okay.
That's why you'll go ahead with selective beta blockers, like metoprolol, or in emergency conditions you can use esmolol as well.
Esmolol, ma'am. Yes, ma'am. Emergency, I will go for esmolol, ma'am. Since it's a rapid acting one and it is of short duration, I can titrate to the response easily. So I will go for esmolol during acute atrial fibrillation, ma'am.
Yeah. Regarding digoxin, many of the centers have stopped using, but still, for exam purposes, and some old examiners also come, you should know about digoxin usage.
Yes, ma'am.
And what are the problems with digoxin? What problems you anticipate with digoxin? How do you give it? What is the dosage? Can you tell in detail?
Yes, ma'am. Digoxin, the mechanism of action is that it will prolong the effective refractory period and it will decrease the AV conduction. Hence, it will maintain the sinus rhythm in atrial fibrillation patients, ma'am. And digoxin is it has a very narrow therapeutic range, ma'am. So, hence, anytime the patient when going for toxicity, we should watch for signs of toxicity in CNS. She can have convulsions. She can develop convulsions and all these things. And serious arrhythmias can develop in GAT, nausea, vomiting. Anything may develop, and she's more prone for this electrolyte imbalance, that is hyperkalemia, and hyperkalemia can occur due to the digoxin toxicity. So we have to, in case of acute AF, digoxin has to be given in a dose of 0.25 milligram over 1 to 2 minutes. Maximum dose of 1.5 milligram can be given, ma'am. And then if I want to continue as an infusion, I can give it at a dose of 0.175 milligram to 0.375 milligram. But digoxin can never be used alone, ma'am. It has to be administered with some other rate control agents. Digoxin as such cannot be used for control of atrial fibrillation, ma'am.
Yeah. If patient is already on digoxin for the purpose of rate control, you continue it. That is the indication now left. Otherwise, it is better to avoid it. If patient is already on, you can continue for the purpose of rate control.
Yes,
and it can cause all the arrhythmias.
Yes, arrhythmias are more common as a ventricular bigamy is except sinus tachycardia, ma'am. Sinus tachycardia won't occur. Other arrhythmias like bradyarrhythmias, ventricular bigamy, ectopics, and
conduction blocks can also
conduction blockades also. Mobitz type 2 blockade.
All type of arrhythmias can happen.
Yes, ma'am.
Some Mobitz type 2 arrhythmias. All the arrhythmias can happen with digoxin. So monitoring of potassium and arrhythmias is important when the patient is on digoxin therapy.
Yes, ma'am.
Okay. Then what are the sir has already has made our job easy. He has already touched upon the surgical management. But still in pregnancy, I want to know what are the surgical options and when that has to be advocated.
Ma'am, surgical options is the balloon mitral valvotomy, ma'am. Since that is, if we before pregnancy, the patient can go in for commissurotomy. But since the patient is pregnant, I would like to go for the percutaneous mitral valve commissurotomy. And the safest period in which
what are the indications for that? See, in India, antenatal counseling is the best. If any patient with heart disease wants to conceive or mitral stenosis, so cardiologists and team anesthesiologists, obstetrician, they all can sit and decide. But
Yes,
in
ma'am.
India, it doesn't happen. They usually come after pregnancy.
Yes, ma'am.
So when do you think, what are the indications for the percutaneous
Balloon
commission?
mitral valvotomy, the indication if the patient has some significant disease and if it is going to be an isolated mitral stenosis, not associated with mitral regurgitation, and the valve should not be calcified, the valve should be pliable, and the left atrium should be free of thrombus, ma'am. So these are all
Only
the
then you can go
going
ahead.
for, yes, ma'am.
If it is done at what stage of pregnancy it is done?
It is the most preferable period is the second trimester of pregnancy, ma'am, because during the first trimester it is the period of organogenesis. So exposure to any drugs may be more teratogenic to the child.
You are worried about drugs in TMC, or you are worried about something else?
Fetal loss, ma'am. In open mitral commissurotomy, the fetal loss.
Radiation exposure to the fetus.
Radiation exposure, yes, ma'am. Radiation exposure. So it can be during the period of organogenesis, there can be teratogenesis, and radiation exposure we have to avoid, ma'am. And in third trimester, the patient, any surgery might promote the preterm delivery. So hence I consider the second trimester to be the safest period for undergoing the percutaneous commissurotomy, ma'am.
Yeah, they say around 20 weeks is best, because
Yes.
apart from the second, it's the best phase when the radial exposure has a minimum effect on the fetus. That's why
Yes,
they
ma'am.
do this procedure around 20 weeks of pregnancy. What
Yes.
precautions are taken during the procedure?
Abdominal shielding has to be done, ma'am. In order to prevent that radiation exposure, abdominal shielding is done, ma'am.
Shielding is done, but still the exposure has to be minimum
Yes, ma'am.
time. So you can use other like transthoracic or transesophageal echocardiogram
Okay,
to
ma'am.
know the position and to know the way, whatever factors you want to assess during the procedure. You can make
Okay.
use of echocardiography more than the radiation exposure. So
Yes,
only at vital times they can do the radiation exposure along with abdominal shielding.
Shielding. Okay.
Yeah, you were telling about some criteria, no, during the first case presentation. What is that? Wilkins criteria.
Wilkinson's criteria, ma'am.
Yeah,
Wilkinson's
what is that?
criteria. It involves 4 components, ma'am. Leaflet thickening and mobility and calcification and subvalvular thickening. Each will have 4 index, ma'am. So they will have total, each is allotted 1 point. So total there will be 16 points. If if it is less than 9, there is going to be a good outcome. The patient undergoes the percutaneous mitral commissurotomy. Whereas if the score is more than 11, the outcome is not so better for the patient, ma'am.
Okay, that is to know the peri-procedure outcome of the patient.
Yes,
Okay. So if all these things are there, what are the options for the patient? If it is not suitable for the percutaneous procedure, what is the option left for the patient?
Then we have to go for open mitral commissurotomy, ma'am. Open mitral commissurotomy is, in general, the outcomes are better for the mother in both the cases, but the fetal loss is more in open mitral commissurotomy, ma'am. There is going to be a 1:8 ratio, like 8 times more fetal loss is there when compared to percutaneous commissurotomy, ma'am.
Yeah, around 20 to 30% of fetal loss is expected,
Yes,
and it is a very risky procedure.
yes,
So real risk benefit analysis has to be done in these cases. If it is early pregnancy, if they want to terminate, that option should be given to the patient,
yes,
because it's a question of maternal life as well sometimes. So
Yes,
the risk benefit analysis has to be done with the entire team, with the patient and relatives.
yes, ma'am.
What about open procedures in pregnancy? Mitral valve replacements and all?
So mitral valve replacement, if there are first as from the history, we have the patient only with a moderate severity, and she's only has mild symptoms, ma'am. So I would like to, if the patient, if I'm able to go with this itself, or else I would like to wait till the pregnancy is after the completion of the pregnancy. I would like to go for the mitral valve repair, ma'am, because.
Yeah, it is very rarely done during pregnancy, but though in developed countries, I think they do immediately post cesarean also. They do. Rikesh sir can add a point. We have the cardiac anesthetist with us on this.
Rikesh,
Rikesh sir?
Rikesh, are you? You go ahead, Chaitanya.
Yeah, okay. In very precious pregnancies and all, they do in some of the developed countries. They do. They have both the options. They do LSCS and then immediately post the patient for the replacement. And sometimes they also do balloon. If this thing is early pregnancy and this thing, they may do the valve replacement and then go ahead with cesarean planned section. These options are also there during pregnancy.
Okay.
Now, if a patient already has a mitral valve replaced patient, say mechanical valve, and she has come to you for the safe confinement, whatever. What about her this anticoagulation? Already sir has touched upon that, but I want to know how exactly you take care of the anticoagulation during pregnancy.
Ma'am, at what time she comes to me is what I'm concerned first, ma'am. If she comes during the first trimester, I have to go in for subcutaneous or IV heparin, ma'am. Since because during first trimester, administration of warfarin can cause warfarin embryopathy, ma'am. So I'm more concerned about that. So the ideal time where I would like to give the warfarin is between 12 to 36 weeks of pregnancy, ma'am. In the first trimester, I would go in for subcutaneous or the IV heparin. And after 36 weeks also, I would substitute with the IV heparin and I will continue till the surgery, ma'am.
What happens if you do warfarin in the first trimester?
Warfarin embryopathy, ma'am. It is characterized by the warfarin. It is more prone to cross the placenta. It will cross the placenta. It will cause the embryopathy where the baby will have the chondroplasias and brachydactyly, stippled epiphysis, and all these things can develop in the baby, ma'am. So and also there is also a more risk of bleeding during the first trimester, ma'am. So I should
fetal loss as well, abortions and all.
Yes, ma'am.
Why not heparin throughout the pregnancy?
Yes, ma'am. Heparin can be continued throughout pregnancy, but for heparin, I have to go in for actually ideally for low molecular weight heparin, I have to go in for anti-10A monitoring, ma'am, which is which I won't be able to monitor the patient. So frequently she has to come and then we have to monitor, ma'am.
In which type of heparin will monitor?
In low molecular weight heparin, we have to do anti-10A monitoring, ma'am. Okay. In non-fractionated heparin, we can go for APTT, ma'am.
Yeah. Given a chance in any valve replacement patient, warfarin is better.
Okay, ma'am.
Because that is the best anticoagulant and it maintains in a proper range, which is required for this case. What is INR you want to maintain?
2.5 to 3, ma'am.
Yeah. So this warfarin is best for maintaining this range, but of course you have to do repeat INR. Yeah, and you have to monitor and you have to maintain between 2.5 to 3.5. That is not that easy with heparin. Okay. Very frequent monitoring is required. Yes, and high this thing is also difficult.
Yes.
Okay. So what is the dose of warfarin? How is it started?
Though warfarin, it can be started at initially at a low dose, ma'am, 1 milligram, or then I'll start at
maximum
5 mg can be given, ma'am.
Yeah, it is given in the range of 5 to 10 mg. Less than 5 mg is associated with very low fetal risk. Okay. Even in very, very high risk cases, they give less than 5 mg even in first trimester, but better to start in second trimester and then monitor and adjust the dosage. Okay. What about heparin? What is the dosage?
0.4 ml we have to give of low molecular weight heparin, which
it depends again whether you are giving unfractionated heparin or
low molecular weight
heparin. Low molecular weight you can give depending on whether you are giving therapeutic or preventive 5 to 10,000 units BD you can give. Okay. If you are giving unfractionated, you can give subcutaneous doses. That also you can give BD. Okay. Okay. Now a patient who is on anticoagulation comes first. Comes in labor.
Okay, ma'am.
How to go ahead?
First, warfarin, I would see whether the patient is on warfarin, ma'am. We have to stop. Ma'am, it's an elective surgery or an emergency surgery?
Emergency. She has come. She is she is on warfarin and she has come with emergency labor and distress. How to go ahead?
Ma'am, ideally we have to bridge the warfarin, ma'am. In case of elective procedure, normally we would stop.
How long you, if given a chance, how long you want to stop warfarin?
5 days before surgery, ma'am. In an elective case, I have to stop 5 days before surgery. On stopping, on the 3rd day, I will start the low molecular weight heparin, ma'am. And then I will continue till the surgery. And I will stop, since it's a therapeutic dose, I will stop 24 hours prior to surgery. And then I'll go ahead with the surgery. And soon after the surgery, we have to resume both warfarin as well as the low molecular weight heparin. And we have to continue low molecular weight heparin for at least 3 to 4 days. And after which the warfarin can be continued, ma'am.
Okay, given a chance, you want to do all this.
Yes,
but patient has come in for emergency LSS and patient is on, she's on warfarin.
Yes,
so how will you take care of this situation?
So first I will order a coagulation profile and I will see how much is the INR, ma'am. And I will see the INR, and then for emergency reversal, I would going for transfusion of FFP, ma'am, fresh frozen plasma. I will give, and I will take up the surgery with arranged adequate blood and blood products. I will anticipate the blood loss, and I will initially itself I'll do the blood grouping and typing, and I will arrange for necessary blood products, and then I will take up the surgery, ma'am.
Yeah, you can go ahead with FFP infusion up to 15 ml per kg, or you can do repeated the monitoring and again decide till the INR comes below
1.5.
To at least below 2.
Okay.
And you can also give additional, along with that, what else can you do? To antagonize warfarin?
For
any other thing you want to give to antagonize the warfarin action?
Intraoperatively, I would give vitamin K can be given, ma'am. Vitamin K can be given, and also to control bleeding, tranexamic acid also can be administered to the patient.
Yeah, you can give vitamin K, 10 mg IM, or if there is no time, you can also give IV as well. 2 to 3 mg you can give IV.
Okay.
That will help to reduce action of warfarin.
Yes,
okay. Then, if the patient is on heparin, how will you go ahead?
If the patient is on low molecular weight heparin and if she is on a therapeutic dose, I would stop 24 hours prior to surgery.
No, for emergency when they have come.
APTT. Yes, ma'am. I will ask for an APTT, and then I will. If it is
heparin, how it is antagonized?
Protamine sulfate, ma'am. Yeah. Protamine sulfate for every 10 units. For every
there is no time that you cannot wait for the at least minimum 6 hours.
Okay,
you can give.
Yes, ma'am. Protamine.
What is the dose of that?
1 milligram protamine for every 100 units of heparin, ma'am.
Okay. Okay. And in case of this warfarin therapy, if prothrombin complexes is available, you can go ahead with that also.
Yes, ma'am.
Along if it is not available, you can use FFP.
Okay.
Okay.
Yes,
okay. This is about anticoagulation. Okay.
Yes, ma'am.
Then say this patient has come for the labor anesthesia.
Yes, ma'am.
Full-time patient with mitral stenosis, NYHA grade 3.
Okay.
Say around 1.4 borderline grade 2, grade 3. She has come for safe confinement and she is in labor. How will you go ahead?
Ma'am, she belongs to the moderate category, ma'am. So hence, first, in the first place, I would like to go for the vaginal delivery assisted with labor analgesia, ma'am. I would go
what
for
are
that.
the indications for cesarean?
Cesarean section is mainly it is due to the obstetric any obstetric indication, ma'am. If there were any baby complications like fetal distress or emergency situations to the baby or the mother, if the mother has some emergency situation, is that where the LSES is indicated, ma'am. Or else I would go in for safe confinement with vaginal delivery and with labor analgesia.
Yeah, how will you go ahead with labor analgesia? Why do you want to give labor analgesia to this patient?
Ma'am, during the first stage of labor, there is going to be the pain is mainly it is a visceral type of pain, ma'am. From the T10 to L1, I have to alleviate the I have to produce a sympathetic blockade there, ma'am. In second stage of labor, I have to produce at the level of S2, S3, and S4. The prudental nerves I have to block. So when the patient comes, I have to ideally give the labor analgesia during when the if she is a primary, I will give when the cervix is a 5 to 6 centimeter dilatation, and if she is a multigravida.
Still follow? Is that still follow? Will you wait for the patient to have so much of pain till 5 to 6 centimeter dilatation? See, you are giving labor analgesia to alleviate the pain and mainly the tachycardia associated with the pain, isn't it?
Okay.
So, given a chance, if you have, you can place the epidural early, or you can activate when required, or as soon as the patient starts having pain, or whenever nowadays the indication is as soon as the mother, like pregnancy, they ask for analgesia. Go ahead and give epidural. Okay. So, waiting, no need to wait till 5 to 6 centimeter of dilatation. Main aim is to alleviate the pain and tachycardia and all other effects. So you can go ahead early.
Okay.
In MS patient.
Yes, ma'am. Yes, ma'am. Okay. So I will give the labor epidural in L3, L4 space. Normally, we will thread the catheter up to 6 centimeter in the epidural space. Here, I would want to introduce it further up to 7 to 8 centimeter. And in the first stage of labor, I will give 4 to 8 ml of drug because the sensory level.
How will you confirm your placement?
Ma'am, I can use the saline push technique, ma'am. Because in pregnant patients, instead of loss of resistance LOR technique, I would rather prefer the saline push technique, and I will confirm whether it is in the epidural.
Yeah, saline push, the dural tap chances are less. You said you said it higher, why?
Ma'am?
You said you'll thread it 7 to 8 centimeter inside the.
Ma'am, I have to achieve a sensory level of from T10 to L1 during the first stage, and in the second stage, I have to reach up to S2, S3, and S4, ma'am. So for the first stage, since I have to cover from T10 to L1, I'm securing it L3 and L4, ma'am. So I would advance it a little further to cover the sensory level required during the first stage of labor, ma'am.
Then later, what will you do?
Ma'am, later, I'm just going to increase the volume of the drug, ma'am, to reach the sacral segments, ma'am. In the first stage, I can go with 5 to 10 ml or 4 to 8 ml of drug during the first stage. Whereas in the second stage, since I have to cover a large number of segments, I'll give 10 to 15 ml of the local anesthetic, ma'am.
You can give the recommend position as well. You can give a little bit of sitting position to enhance the pelvic fibers, pelvic nerve fibers. Okay, how do you confirm the epidural location? Like, how will you rule out subarachnoid or intravascular?
By giving test dose, ma'am. In this patient, since my patient has mitral stenosis, I would avoid adrenaline in the test dose. Directly, I would go in for 3 ml of 1.5% lignocaine. I will give. And I will wait for another 3 minutes, and I will check for any loss of hip flexion, ma'am, to confirm the placement in the subarachnoid. If it is accidentally in the subarachnoid space, then there could be a loss of hip flexion, ma'am. In my patient, I cannot add adrenaline, ma'am. If I could add adrenaline, I would see an increase in heart rate of more than 20 to 40 within 30 seconds of administration. That also will confirm the accidental placement.
Yeah, again, regarding this epidural district, there are two schools of thought. Okay, some of them still go ahead thinking that hardly 5 to 10 mics of adrenaline. Yes, again, you have to weigh the risk and benefit.
Okay.
Like, it is better to rule out confirm the epidural placement, they say. Some of them say it is the right already basal tachycardia is there and you're further increasing like that. But whatever you say in your exam, okay, you just justify. Okay, but if in my during my cases, I do give 2 to 3 ml of lignocaine with adrenaline to confirm the position, and I have observed that there is no much increase in the heart rate. Okay, so that should be fine, I feel. because the negative aspiration doesn't rule out intravascular placement. That is why in pregnancy especially. So it is better to give, I do give, but in exam, whatever you say, you justify your answer.
Yes, ma'am.
Okay. Then regarding this epidural placement also, you try to keep around 3 to 5 centimeters in the space because of migration, and this thing is also chances of intravascular, this thing is very high because highly engorged vessels are there. So you can take care of that.
Okay.
What are the other options for epidural labor analgesia?
Ma'am, there are non-pharmacological methods also, ma'am. Non-pharmacological methods like acupuncture and then breathing techniques also can be told to the patient, wherein we give a coordinated approach, ma'am. Like we have to train the patient that this is a natural process where we have to teach her the breathing techniques also. And then we can also go in for TENS, ma'am, transcutaneous electric nerve stimulation. In that we have to place two electrodes, and the TENS, it works on the gate control theory, ma'am, wherein the pain impulses are not even delivered to the substantia gelatinosa. So the non-pharmacological methods I can go in for, ma'am. Others are nothing but the pharmacological methods. In pharmacological methods, I can go in for IV opioids I can go in for, ma'am, or inhaled opioids can be given. And in neuraxil, apart from epidural, we can also give combined spinal epidural, caudal and paracervical and pudendal nerve blocks can also be given, ma'am.
Okay, we'll discuss that again now, regional versus GA. But you can opt for other options then. You are not able to do because of severe NIH3 and 4. You can consider other options as well.
Yes.
Okay.
Yes,
okay. Then suppose this patient goes in for LSCS.
yes, ma'am.
How will you go ahead?
Since I already have an epidural in place, I would take up the patient under epidural anesthesia. I would give the graded doses of local anesthetics necessary to achieve the appropriate sensory level, and I will proceed with the epidural anesthesia, ma'am. Additionally, if I want to give, I would supplement with a low dose spinal also can be given, ma'am.
Better don't utter words spinal.
Okay.
My suggestion.
Yes,
To always go, safety is most important, and in MS you don't want to give spinal. Okay, because the fall in SPR will not be tolerated by the cardiac output. Okay, condition. So you always play safe. Go for graded epidural.
Okay.
Time is there, and if there is no time, if there is severe distress, you stick to general anesthesia.
Yes.
Okay? Because you have to consider the safety. That is most important.
Yes.
So suppose there is severe distress and you are going well with general anesthesia. How will you do it?
In general anesthesia, initially I would pre-medication. I would not want to give much of pre-medication, and I will give the anti-aspiration prophylaxis to the patient in ward, and immediately after shifting to theatre, I would go in for modified rapid sequence induction. I would like to prefer in this patient, ma'am, because since she is a pregnant patient, I would go for modified rapid sequence induction. Initially, I will give fentanyl at a dose of 2 mics per kg, and I will also give thiopentone. Since actually ideal is etomidate, ma'am. Since we don't have etomidate here, I would go for thiopentone. I will give the sleeping dose of thiopentone. Here, during the modified rapid sequence induction, is where first while I'm doing the pre-oxygenation, I would try to give the minimal number of the positive pressure ventilation, and I will also ask another person to give the cricoid pressure till I secure the tube. After giving the sleeping dose of thiopentone, I will give the succinylcholine 2 mg per kg, and I will secure tube. In pregnant patients, I will always go for smaller size, one size smaller then the routine tubes, and I will secure. And after the cuff is inflated, I will ask the other person to release the cricoid pressure, and then I will supplement with the muscle relaxant, non-depolarizing muscle relaxant. I will give ecuronium at a loading bolus dose of 0.1 mg per kg, and in inhalational anesthetics, I will keep it as sub-anesthetic doses, ma'am. I will maintain it at a lower MAC.
Okay, go ahead.
Yes, ma'am. And for maintenance of the anesthesia, so I will give nitrous oxide and oxygen in a combination of 50:50%. Nitrous oxide can be avoided if the patient has pulmonary hypertension. And for maintenance, I will give adequate opioids and non-depolarizing muscle relaxant, vecuronium I will give. And inhalational anesthetic maintained at appropriate doses. And after the surgery, after the proper reversal of the non-depolarizing muscle relaxant, I will extubate the patient without after adequate analgesia. I will extubate the patient.
Okay, nitrous oxide you avoid. If any sign
Okay.
of pulmonary hypertension is there, you better avoid the nitrous oxide. You won't tell that.
Okay.
And what are the problems? When do you expect the problem in during normal? Like, what
In
are the
general
points?
anesthesia, I am more concerned with the airway, ma'am. Since they are pregnant patients, generally they will have there will be increased capillary permeability, and hence they can have an airway edema is more common in them. The pre-op Mallampatti classification is what we see is not going to be the exact situation while we are going to intubate because of the increased capillary permeability and airway edema, ma'am. So I'm more concerned with the airway in case of general anesthesia. And
no, I'm asking which are the points when you need to be careful in a patient of MS with cesarean, like when you expect some
during
complications.
induction. During induction, ma'am. During induction, if, I should not decrease the SPR to such an extent that it can lead to decompensation, ma'am. So we have to give any drug. It should be given a graded manner. And I will also like to avoid propofol since it can cause a decrease in SPR. I have used thiopentone and I've given it in a graded manner to.
No, to blunt the stress response.
Yes, ma'am.
You want to add something else?
I have to give adequate opioids has to be given, ma'am, in order to blunt the stress.
But you have to consider fetal circulation as well. Fetal is still in place.
Yes, ma'am.
So what are the other options? Opioids, you can't give full dose to blunt the stress response, isn't it? Because you have to take care of fetal-maternal circulation as well, isn't it?
Yes, ma'am. Yes, ma'am.
So what are the other options?
Ma'am, adequate.
You only half dose, or some people even don't give opioid. They give after fetal extraction. Even if you give, you have to inform the neonatologist.
Yes, ma'am. We have given opioids. Yes, ma'am.
Yeah, you have given. They have to be ready to handle that.
Yes, ma'am.
To use other agents which are safe.
Under beta blocker coverage, I can induce the patient, ma'am. Since the esmolol is of rapid onset and short duration of action, I can use it at a ratio of 500 mics per kg IV bolus, and then intraoperatively, if I want to continue, I can give it an infusion rate of 50 mics per kg per minute up to a maximum dose of 200 mics per kg per minute, ma'am.
Yeah, you can continue on this one, or you can also do a dose of metoprolol as well.
Yes, ma'am.
You don't have the facility to do the
yes, ma'am. Yes,
okay. So better to use additional drug rather than giving high opioid in this patient.
Okay.
And you have to always tell in any pregnant patient aspiration prophylaxis.
Yes,
how you are shifting the patient in left lateral position. And intraoperatively you have to mention about iotocaval compression, what weight you are giving.
Yes,
okay, that is very important.
Okay,
and you have to make a note of oxytocin, what you are going to give.
Yes, ma'am. So
Yeah,
immediately after
that.
delivery, I will give 10 to 20 units of oxytocin in 1 liter or 1000 ml of crystalloids in a slow manner, because oxytocin by itself, it can cause the hypotension, the vasodilatation can occur, so that could produce a reflex tachycardia. So I would give in 1000 ml of crystalloid.
Slowly you want to give the
Slowly I want to give.
Okay, fine. What about other options? Apart from oxytocin? Other oxytocin, anything?
Ma'am, I would prefer to avoid methergine, ma'am, because it causes tachycardia. I would prefer to avoid methergine and also carboprast. I would try to avoid, ma'am. I would go with oxytocin.
What about carbitocin?
I will
in severe conditions, carbitocin also has to be avoided.
Okay, ma'am.
Then you told the points of stress during the procedure. One is intubation. What are the other points where you have to be careful?
Ma'am, during extubation, ma'am. Extubation is also the.
So that during the procedure.
During the incision, ma'am, when the surgeon the first initial surgical stimuli, at that point also I have to be cautious to maintain the adequate depth of anesthesia in order to prevent the further sympathetic stimulation, ma'am.
After fetal extraction?
Yes, ma'am. After fetal extraction is where this auto transfusion will occur, ma'am. At that time, there is going to be increase in the venous return, and the patient may not be able to cope up with that one, ma'am. So at that time, I will be cautious, ma'am.
Yeah, if you notice some rise in your peak airway pressure, what do you suspect, and how will you go ahead?
In peak airway pressures, first I would assess the compliance of the bag, ma'am. If it is if there is increased resistance, I would see whether if there is any secretions or blood, or if anything is there causing the obstruction, and I would do a thorough suctioning of the ET tube.
Before that, what do you suspect in MS patients? Immediately after extraction, you are seeing rise in pressure.
Pulmonary edema, ma'am.
Then how will you manage that situation?
Yes, ma'am. For pulmonary edema, since the patient is already in GA, I would directly go in for to administer positive pressure ventilation has to be given, ma'am. I've already used oxygen, so 100% oxygen, and then I will give positive pressure ventilation.
This is a case of MS, you want to use low tidal volume, you want to, maintain, isn't it? You have so many goals, no? For that you are going a bit low tidal volume.
Yes,
then what will you do now?
Medications like intra medication, Lasix can be given, ma'am. Lasix and morphine can be given, ma'am.
Yeah, don't go like routine case. Don't go with high peak and this one high positive pressure. For make use of the medication, you can go ahead.
Diuretics can be given, ma'am.
Yeah, Lasix will give you immediately. It will take care of whatever auto transfusion has happened. It will help to fix. Okay, what are the points? What else you can have intraoperatively? What are the problems? Suppose there is hypotension. What will you do?
Hypotension, I would go in for the pressors, ma'am. I would try to avoid ephedrine, or I will go with phenylephrine, ma'am.
Why phenylephrine?
It is a direct acting alpha agonist. In ephedrine, there is also going to be beta action, which can cause the tachycardia, which is not favorable for the patient. I would go for phenylephrine, which is a direct acting alpha agonist.
Okay. What if there is arrhythmia? If you notice intraoperatively.
So intraoperatively,
simple tachycardia is there. What will you do?
Ma'am, first I would confirm why there is tachycardia, ma'am. If the patient is in light plane of anesthesia, I would like to deepen the plane of anesthesia to further avoid any sympathetic stimulation. Or if the associated if hypotension is there, then I would like to rule out the causes of hypotension, whether the patient is in hypovolemia or if it is due to the bleeding, whether there is any massive hemorrhage. I would rule out the causes of hypovolemia. I would treat the hypovolemia. Then I will maintain the adequate depth of anesthesia. With that, I can given supplemental doses of opioids also should be given, ma'am. If the cause is corrected and if the tachycardia settles, then I would go.
Yeah, not only inadequate doses like anesthesia, we also rule out other causes. Like, what are the other causes for tachycardia?
Hypotension, hypovolemia. Hypoxia, intraoperatively, if patient goes in for hypoxia, hypercarbia, all these things can produce
and hypothermia as well.
Hypothermia.
AC is there everywhere. Na? So
Yes, ma'am.
hypothermia also you rule out with the patient warm. Okay, so rule out all the causes of tachycardia,
Yes,
see
ma'am.
it accordingly, and then you can go ahead with the dose of beta blockers.
Beta blockers. Yes.
What about bradycardia?
Bradyarrhythmia.
Bradycardia, what to do?
Ma'am?
What if there is bradycardia?
Bradycardia also is not allowed in this patient, ma'am. I will see for the causes of
Bradycardia is good, no, in MS.
low to normal, not exactly bradyarrhythmia, ma'am.
Less than 40 is
Why
not
you are worried about bradycardia?
Ma'am, bradycardia already, it's a fixed cardiac output status, ma'am.
We
So
can't
I
allow-
need
Go and
to
fix
maintain a
cardiac
normal.
output. Hmm?
Yes, ma'am.
So the fetal circulation is further hampered.
Yes, ma'am.
Even after that, in the fixed cardiac output, you have to maintain normal heart rate because stroke volume cannot be altered. It is only through
Yes,
heart
ma'am.
rate. Some amount of cardiac output has to be maintained, so you have to maintain heart
Yes.
rate. You can't permit bradycardia. Good means not lower. You have to maintain around 70 to 80 is ideal, not
Okay.
less than that. Okay.
Yes.
So even bradycardia, you should take
Avoid.
it. Okay.
Yes, ma'am.
Then what about monitoring?
Monitoring.
Which monitors you opt for? In these cases?
I would go for the standard ASA monitors, ma'am. ECG, NIBP, saturation probe, and temperature monitoring. Since I've induced with GA, ETCO2 is also I will prefer. And since I have a patient of moderate MS, I can also go in for the invasive monitoring like IABP, ma'am, intra-arterial blood pressure monitoring to monitor the hemodynamics.
Yeah, arterial you want to place.
Yes, ma'am.
Yeah, you want to have the beat-to-beat variability.
Yes,
So it
ma'am.
is good. Okay, and you can also opt for just one echo prior to cesarean if you have either transthoracic you can do, or if you have the option you can do T also, especially in case of G and CO, you can opt for that.
Okay.
That will also guide. It will also help for fluid management as well.
Yes, ma'am.
So you can go for invasive monitoring if the severity is more.
Yes, ma'am.
Okay. Then what about this one? Post-operative management.
After adequate analgesia has to be given, ma'am. Even in the post-operative period, we have to maintain the goals which we followed intraoperatively. That is, we should avoid further tachycardia. We should maintain the adequate analgesia has to be given for the patient, ma'am. Since I have an epidural already in place, I can make use of that in the post-operative period to give adequate analgesia, and I can also go in for other systemic analgesia. Intraoperatively, I can go in for para infusion, 15 mg per kg. I will give, ma'am.
I can use lower dose of bupivacaine or
propivacane
infusion faster.
Okay.
In the post-operative period, again you notice some arrhythmia, some irregular pulse of things.
Yes,
what will you think, and how will you go ahead?
First, I will order for a 12 lead ECG, and I will confirm what rhythm the patient is in. Ma'am, I think the patient is in atrial fibrillation. If the patient is in atrial fibrillation, I would like to go for the rate control and rhythm control. For the rate control, I will go in for the beta blockers, calcium channel blockers, or digoxin can be given, ma'am. For rhythm control, I will give amiodarone 150 mg IV stat followed by an infusion, that is 1 milligram per minute, 1 mg per minute for the first 6 hours, and followed by 0.5 mg per minute for the next 18 hours. And
if unstable, if the patient is with unstable hemodynamics, cardioversion is an option, ma'am.
Synchronized cardioversion biphasic 100 to 200 joules can also be given if the patient is hemodynamically unstable and not responding to the medical therapy.
Yeah, if it is acute AF, it is fine. If it is chronic AF, you want to have any other thing in your hand? You want to know something else?
The medical management is I go with
cardioversion.
Medical management only, ma'am.
Before doing cardioversion, you want to have
a TE has to be done to rule out any thrombus has to be ruled out, ma'am. Adequate if the patient is a chronic one.
Transthoracic only. It is
yes, ma'am.
Yes, you can do transphorasis if it is chronic. If it is
Yes,
more
ma'am.
than what time you are worried of thrombus?
Chronic.
Fibrillation persisting for how long has the chance of thrombus? Yeah, it has to be more than at least 24 to 48 hours. That
Okay.
when it happens continuously for a long time, there is chance of thrombus. But not all AF cases going for thrombus.
Yes,
What
ma'am.
I'm trying to tell you, if there is stasis for more than 24 to 48 hours, there is chance of thrombus formation. In that case, before cardioversion, you have to ask for
Echocardiogram to rule out the thrombus.
rule out the presence of thrombus.
Thrombus.
Yeah. Then this AF cases,
Yes,
pregnancy with atrial fibrillation. Do you want to use anticoagulation?
Yes, yes.
In what situation? In all cases of MS with AF, you want to anticoagulate, or are there any indications for that?
Already the patient is in a prosthesis, mechanical valve prosthesis now. The mitral stenosis.
No, I told as MS with AF, not all cases develop thrombus, isn't it?
Yes, ma'am.
So, what are the indications for anticoagulation for a patient with MS with AF in pregnancy? MS with AF.
If it is a chronic atrial fibrillation, we can give anticoagulation, ma'am.
No, not necessary. There are particular indications in pregnancy. Say if there is history of any thromboembolic event is there, okay, then you go ahead with anticoagulation.
Okay.
And if the left atrial size is around more than 65 millimeter size, you can go ahead with anticoagulation. Or if there is history of thrombus formation anytime, if there are notice of in any previous 2D echo there is history of thrombus or history of thromboembolic event is there, okay, then you can go ahead with anticoagulation.
Yes, ma'am.
Okay. So LA sizes, that's why once again important during your 2D echo examination to decide regarding anticoagulation as well.
Yes, ma'am.
Okay. So as we discussed 2D echo in detail in the first case scenario, that's why I didn't ask the details of all the investigations, PCG, chest X-ray, and 2D echo because it was discussed in detail. I want to ask one question. Are there any indications for cardiac catheterization in MS patients? In either pregnancy or per se like non-pregnant patient also?
So cardiac catheterization can be done to look for to rule out the other associated abnormalities, ma'am, other valves and other.
If you find any discrepancy between patient symptomatology and your 2D echo findings,
okay.
If there is a lot of discrepancy, your findings are the value there something different, which is not correlating with the patient symptoms, you can go ahead with
cardiac
catheterization. Yeah, cardiac catheterization, you can go ahead.
Okay.
If there is any difference, or you can also catheterize, like in your case, if you are confused, like whether it is in your first case, the patient has history of chest pain.
Yes.
Okay. If it is not correlating with the severity of the MS you are finding, or this you want to confirm or rule out, you can go ahead with this one. Okay, cardiac catheterization.
Yes, ma'am.
Rajesh, sir, how much time do you have?
No, actually, time up. Shall we go ahead with the questions from the chat box? Some questions are there for you.
Okay. Okay.
Thank you. No, I picked up only one or two questions because other questions they have answered there itself. If it is of fetal distress condition for emergency LSAs, when the patient is having epidural catheter in situ, so what drug is preferred? Whether we can go for lignocaine or butylating?
Yeah, it again depends on the fetal distress and obstetrician's distress as well.
From PD's point of view, I think better to answer general anesthesia in this situation, right?
Yeah, that's what it is better to go ahead with. If you don't have time, see, when you put the epidural, you have to patient has to have the benefit of the epidural. You have to give it in graded way. Yeah, it requires at least 10 to 15 minutes time. If you don't have that much of time, better don't take risk, because obstetrician distress will come on you and as well as patient. So go ahead with GA. I would prefer general anesthesia.
Any role of newer oral anticoagulants in this? Newer oral anticoagulants for pregnancy post valve replacement?
Yeah, the post valve replacement. I have no much idea. I want other seniors or cardiac anesthetists to take over this question.
Sir, can you ask the question again? I didn't get.
No, the role of newer oral anticoagulants instead of warfarin.
Okay.
Newer oral anticoagulants post MVR patient.
Okay.
In pregnancy.
Post prosthetic mitral valve.
Post mitral valve replacement.
Okay, sir. Warfarin and acetylene are the only drugs standardized as of now for post valve replacement.
Yeah,
there is no.
It's a question from a postgraduate, so we have to give the answer that there is no role for that.
Yes, sir.
Line. Okay. Okay, Rikesh, there was one question by Chaitanya that what is your comments on percutaneous mitral commissurotomy in pregnancy? So when to do, exact time?
Sir, second trimester will be ideal, but nowadays, you can do it any period of time, even before pregnancy. Also, you can do. Why? Because cardiologists started doing PTMC under echo guidance. No need for fluoroscopy. If they are experienced enough, they can do under echo guidance also. But they should accept. They should accept for suboptimal results, which will cope up the patient for this duration of pregnancy. But the ideal time, if you are going with fluoroscopy, is second trimester, beyond 20 weeks.
Is this the answer you wanted, Chaitanya?
No. I wanted the answer regarding mitral valve replacement done during pregnancy.
Yes, sir. We can that also. It is rarely done under tocolytic. This thing under tocolytic coverage, you can do mitral valve replacement in a pregnant patient. That too in second trimester or early third trimester.
Yeah, they do along with cesarean as well, just prior to cesarean or after cesarean.
Depends on the age of the baby, ma'am. If the patient is not tolerating the symptoms and all, you can go ahead with. But as known, the risk will be higher for delivery, this thing and all. You can. There are many cases reported in India that did successfully under the coverage of tocolytics.
Okay. So there is no much other questions. Thank you, Dr. Rikesh and Dr. Chaitanya for this wonderful discussion. And thank you, Praveena and Ramya, for your presentation. Thank you very much.
Students, you have done well. Ramya and Praveena, you have presented well. And I also want to thank Rajesh, Rikesh sir, and Guru Santhya, and entire team of online anesthesia. I want to thank for giving me this opportunity.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am.
Thank you, sir.
Well presented.
Thank you,
Thank
sir.
you.